become an expert in ultrasound guided cannulation, then the nerve blocks, regional blocks, everything can be done. Okay, and as Ashfaq Bhai said, today you are one of the luckiest top 60 people who are learning this, that this thing actually exists in this world. Okay, and if you can use this and implement this, you can save a lot of lives. ठीक है, आप इसको दो तरीके से देख सकते हो, आपको ज़िंदगी बचानी है इससे, ठीक है, और लोगों की तकलीफ कम करनी है। अगर सिर्फ यही दो एम करके देख ली ना अगली प्रेजेंटेशन में, और आज इसको आज कम्स टू यू और आपको पता चलेगा कि यार मैं इस पे अल्ट्रासाउंड प्रोब रख के यूज़ कर सकता, यूज़ कर सकती हूँ। सिर्फ ये मत सोचना कि मैं नहीं कर सकती या मैं नहीं कर सकता, तुम सिर्फ ये सोचना कि अल्लाह मियाँ क्या मैं इसकी तकलीफ दूर कर सकती, मैं इसकी तकलीफ दूर कर सकता हूँ, ठीक है, और क्या मैं इसकी दूर कर सकता हूँ, ठीक है, और क्या मैं इसकी ज़िंदगी बचा सकता हूँ। इसका आंसर हमेशा यस से आएगा। बस अभी कॉन्फिडेंस होता 0.1% भी कि यार मैं इसकी लाइफ बचा सकता हूँ, जस्ट पुट द प्रोब ऑन, फिर देखो अल्लाह ने तुम्हारे लिए रास्ते किस तक खोलता है। I started off very small steps. आज की जो प्रेजेंटेशन है, जो टीचिंग है, उसका मतलब ये नहीं है कि आपको हर चीज़ आ जाए, लेकिन आपको हर चीज़ जो कि आ सकती है इन द फ्यूचर, वो आपको आ जाए। आपको पता चले लाइफ किस तरह सेव हो सकती है एक छोटी सी चीज़ से। जैसे अजीम भाई ने बोला था हमें तो ट्रिपल ए मिलते ही नहीं है, क्यों नहीं मिलते? पहले ही मर जाते हैं, यही बोला था हमने। अगर आप उनकी लाइफ सेव कर लो, आइडेंटिफाई कर लो ट्रिपल ए, आस्क द वेस्कुलर सर्जन्स टू कम इन, डन, योर जॉब इज डन। बाकी जिंदगी और मौत अल्लाह के हाथ में, ठीक है। सो व्हेन यू लुकिंग एट थिंग्स एंड वी आर नॉट कॉन्फिडेंट, जस्ट स्पीक टू योरसेल्फ, अल्लाह मेरे बात करके भाई मैं ये कर सकती हूँ या नहीं कर सकती, मैं ये कर सकता हूँ या नहीं कर सकता, इसकी लाइफ सेव होगी नहीं होगी। अगर अल्टीमेट एम आपका लाइफ सेविंग है, हो जाएगा। और अगर आपने अल्टीमेट एम ये बनाया कि मैं स्कैन कर लूंगा और मेरे नंबर्स बढ़ जाएंगे, ठीक है, या मैं इसको अपने एलएम पेज पे शेयर करूंगा, ठीक है, तो आप कभी प्रोग्रेस नहीं कर सकेंगे। नीयत आपकी बहुत अच्छी होनी चाहिए इसके पीछे, और जितनी साफ नीयत होगी उतनी तेजी से आप प्रोग्रेस करेंगे। ओके, सो अल्ट्रासाउंड गाइडेड वैस्कुलर एक्सेस, we use a linear probe, which is the high frequency probe. The depth is maximum about 5 centimeters, and you don't need more than that for vascular access. किसी की वेन जो होती है वो बोन के साथ नहीं लगी होती, ठीक है। So again, there's some problem with computer. The slides are very slow. These are the sliding movements, up and down. ठीक है, you see the whole range of movement. ठीक है, आप स्लाइड राइट एंड लेफ्ट करेंगे, अप एंड डाउन करेंगे, you have to differentiate whether it's a vein, whether it's an artery or it's a nerve. Okay, ये मकसद है आपका स्लाइडिंग का, देखने का कि कौन से स्ट्रक्चर्स एडजेसेंट एरिया में। ओके, सिंपल प्रो मूवमेंट्स हैं, अभी हम लोग जस्ट प्रो मूव्स की बात करेंगे। दूसरा कंप्रेशन, once it starts coming up. Compression में क्या होता है? When you compress, you try to differentiate an artery, vein and nerve. What do you think is the most compressible structure out of the three? Vein. Then second one? Artery. What will happen, the difference between compressibility of an artery versus vein? Yes. And what will happen to an artery when you compress that? It will become pulsatile, yes. And what will happen to the nerve? Nothing. Good. So this is the value of compression. What's the use of tilting and tilting or fanning? It's going to come up in a sec. आप फैन कर रहे होते प्रोब को, ठीक है, पंखा चल रहा है, टिल्ट, इसका क्या मकसद होता है टिल्टिंग का? देख रहे टिल्टिंग जी, कैसे, इसके अलावा जी, ऑफ, okay, so the purpose, the main, yes, we can identify the whole pathway of the nerve or vein where it's going, but more importantly, if you want to know the pathway, you have to slide. कि right पे जा रही है vein, ऊपर proximally left पे जा रही है. Purpose of tilting is once you tilt, veins and artery will still appear, but the nerve will disappear. Okay, so we'll definitely know कि यार nerve है, यार कि nerve में कभी inject कर दोगे आप तो लोकल एनेस्थेटिक इंजेक्ट कर दिया, वो तो पैरालाइज कर दिया आपने, उसके पीछे नर्व डैमेज कर दिया आपने, So be very careful. अल्लाह ने आपको authority दी है, उसको बहुत ही carefully, judiciously use करो. You don't have to be 100% confidence, but अगर ये question आए कि मैं इसकी life save कर सकता हूँ, अगर answer उसका है yes, do it. You'll never go wrong. नहीं सही है ना, रास्ते clear हो जाएंगे. अशफाक भाई, ऐसा ही है ना? So tilting or fanning over. Next, rocking movement. Again, once it appears here, I'll show you. Rocking movement भी ये होता है, आप आइडेंटिफाई कर रहे हो एडजस्टेंट स्ट्रक्चर्स को. ये हैंग अप हो गया. स्क्रीन हैंग अप हो गई. यहाँ पे चल रहा है, इंटरनेट चल रहा है, ये लैपटॉप बहुत स्लो है. Okay. Rocking and rotation. Rocking means you hold the probe and you move it rock it sideways. Okay. Rotation में क्या होगा? Once you put the probe on and you rotate it, what's showing here? What's being shown here? Yes, from a transfer to a longitudinal orientation. That's what's going to happen when you rotate the probe. ये सब अभी हम लोग ये वाटर चेक करेंगे, दिखाएंगे आपको, तो इसमें आपको रोटेशन, प्रोब रोटेशन का कॉन्सेप्ट पता चलेगा कि उसकी यूज क्या है. This is once you find the vein, nerve, artery, whatever in a cross section, you rotate the probe longitudinally to see the longitudinal section. Okay. Now, how does the ultrasound probe actually work? The needle visualization, when you put the needle in, there is reflection of images. The ultrasound beam is like a plane of light. Your needle is like a mirror. Okay? If you put an angle of beyond 45 degrees, the chances are the light is going to be reflected at 90-degree angle. Once your needle is 45. See, the light's coming from the top of the probe. Pointer it in, please. Pointer. There's a pointer. Once the light is being reflected on the needle as a 45, the light is not going to go back to the probe. And it's not going to go back to the probe. The chances are you will not be able to see the needle. Okay? So it's been reflected at 90 degrees once the needle is 45. Beyond that, you will not be able to see the reflection of the needle. Okay? So every time, try to put an angle less than 45. If it's beyond 45 degrees, you will not be able to visualize the needle. Okay? See, reflection of the light is going all the way. If it's flat, it's going to be reflected back up. If it's angulated, it's going to reflect it along the plane of the body. Okay? To understand the concept of angulation and seeing the needle. Oh boy. What's slow? नहीं वो पता नहीं है. Just give us like 5 minutes. We'll change it. समझ नहीं आता अभी. अब हम change कर रहे हैं. यही लिंक खोल लें अजीम भाई. So basically, concept here is this is needle visualization. See how flat the needle is. Everybody, have a look. How flat the needle is. Once the needle is at angulation of 45 degrees, you will not be able to see it. So this is how it will appear like if you want to see the needle. If you can't see the needle, the chances are you're going too vertical. Okay? So you need to get the sound waves reflected back to the probe. Okay? Understand?
general inclination is if we try to go perpendicular or 45 degree, you won't be able to see the needle. More parallel you go, better it is. Plus, the more parallel you go, you're less likely to damage any, especially if you're going to the jugular. If you're going parallel, you're less likely to damage any structure. It's more safe.
So yeah, try to go parallel to the probe. Simple. Okay? If you're going perpendicular to the probe, the chances are you'll not be able to see it, and you hit something very important, like a nerve or an artery. Okay, what's the concept of short axis out of plane? When you say out of plane, that's out of the plane of the beam of sound. Literally just a spot. See the pointer? This is what you're going to see. Literally like a spot coming in to the vein. Okay, that's out of plane. When you say in plane, you're going parallel to the sound. So this is out of plane. You're like hitting a wall. You're hitting a wall of sound. Okay, something which is invisible but yet it exists. So you have to use your imagination. This is the sound waves that are going down. You're going out of plane. Okay, and out of plane, this is the circular structure which is like a vein. I will show it to you on someone's hand or forearm कि veins किस तरह नजर आती हैं और out of plane कैसे नजर आएगी, out in plane कैसे नजर आएगी. ठीक है. Next is uh, needle tip versus needle shaft. Again ये अगर अच्छी चलेगी तो नजर आएगी वरना नहीं. Needle tip जो है ना, needle shaft जो है sharp नजर नहीं आएगी. Needle tip जो होगी right like a comet नजर आएगी. So if you're going out of plane, you'll see only one spot, not the whole length of the needle. Okay, this is a pointer. The white line is a pointer, it's not a needle. Okay, so what you will see is once you're trying to visualize the needle out of plane, okay, once you're the needle's hitting the wall of sound, okay, sound waves. So you will only see a rough, irregular structure, which is like a shaft, okay, moving into the patient's body. But once you see like a comet structure, bright structure, that's the tip. That's the tip that you need to visualize, and that's your target. So imagine it's just like a millimeter of width of this beam of sound, echo waves that you have to hit the needle in. Okay, so it's quite a fine requirement of movements of your hands. So out of plane needle tip visualization, how will you say that this where the needle tip is if you can't see the tip? Okay, you can't see the tip, can you? Probably it's here, probably. So what you're going to do, inject some normal saline, and you see saline will appear like this, and you know the tip is here. So you can move forward further and inject more saline, more distally, okay, to know exactly where needle tip is. Simple? This is the tissue displacement method of finding the tip of the needle. Okay? आपको tip नजर नहीं आ रही, but yet you can see it. Okay? So you see the tissues, the fascia, bending downwards, and as you go down, you inject saline, and you know that your tip is here, but you want to end up here, and again you move downwards, you want to end up here, but you're slightly lateral to the vessel, so you move slightly medially. Okay? Because your saline is being injected outside. Saline is safe, isn't it? So we can use that as a tissue identifier of where the end of the tip of the needle is. Understand this? Yeah? Good.
The angle of the needle is
So when you're out of plane, it seldom matters what angle you're holding it. Okay, very little at time. Okay, but when you're in plane, the angle matters a lot because you need to see the whole length of the needle. Okay, you're in plane of the beam of sound. You're out of plane of the beam of sound. You're hitting the wall. And when you're in plane with the beam of sound, your needle is part of the wall. Understand? So out of plane, we have done that. Move next. So Needle visualization angles, we have done that. Gonna move forward. Give me a second, sorry, it's not going now. Yes. Tissue displacement हमने कर ली है. Next we're gonna go for in plane visualization. How will it appear in plane? Your needle is now becoming part of the wall, straight or beam of sound. Okay, beam of sound waves that are coming in. Okay, so you're going parallel to the beam of sound. The needle is becoming part of this wall, and this is how it will appear. It will appear in plane is this. You see the whole shaft of needle. Okay, simple. Any questions so far? Sure? Okay, so this is in plane, but the wrong technique. So what's happening here is you're thinking that you're going in plane, but actually your whole needle shaft is crossing through and through the wall. Okay? And what will happen if this thing happens? That your needle tip is not dead on parallel to the beam. It's going to move out. Okay? Only a section, a very small section of the shaft of the needle is being projected with the beam of sound. Okay? So it's going through and through. The whole thing is not absolute parallel to the wall. Okay? So when you do this, how will the needle appear? Next second. Yes. So what will happen? Is this the tip? You think? The tip is here. See this step appearance? Step ladder appearance, stair step appearance? This is indicative of the tip. Okay? You have to see that staircase appearance like this, see? Which will indicate you are looking at the tip rather than part of the shaft when you're in plane. Okay? Azim bhai, you understanding?
So, in your opinion, which one is the safe? In plane
Which
or
one's
out
the
of
safe?
plane?
In plane.
In plane is safe because you can see the whole length of the needle, so you know where we are going. Out of plane, you can only see the tip, and very soon you will lose that because it can cross the lumen of the other side. So normally I use out of the plane one. That's my practice. But if you're going into internal jugular vein, it's always go to in plane because there are a lot of important structures here. You have to see the whole jugular, you have to see the whole needle. You can't go perpendicular with the out of plane. Yeah?
So,
And one more thing, you can actually find a lot of clots here as well. Jugular vein thrombosis. As soon as you put the probe, sometimes you can find thrombus, which
so
indicates previous ITU admissions, previous something, previous IV jugular veins done.
So then this is all the basics of in plane. You're going in the plane of the beam of sound. Out of plane, you're hitting the beam of sound from like head on. Okay. If you can just understand this from today, that's more than enough. When you're going head on out of plane of the beam of sound, you'll see only one spot. When you're going in plane, you'll see this. The advantages and disadvantages Dr. Shfaq has already explained. Uh, I also go most of the time out of plane, 90%. And there's now the latest literature is saying what Ashfaq Bhai is doing. They're going out of plane for nerves only. Okay? For the rest of the sector, you can go in plane or out of plane. Okay? नहीं समझ आ रही है आपको?
Out of plane में advantage क्या है? What's the advantage?
Out of plane is very easy. Very easy. ठीक है आपको if your hand is still as a neurosurgeon, you know you're not gonna faff about while your hand is on with the probe, okay, and it's not gonna slip, then go in plane. Why not? Okay? But if you know that you won't be able to keep your probe still while you're going in plane, then forget it. Just go out of plane. Yes. Gel के साथ? Yes, get slippery. So I will explain you how to avoid this slipperiness. It's very easy. It's very common sense. Again, no rocket science. I'm not a genius, but I know my limited resources, how I operate, and I'll try to pass it on to you guys. So this is the needle tip in plane visualization. See how this tip is going in. Okay, see the staircase appearance. Okay, and the cannula is in and is protecting the needle. That's in plane. This is how you see. You'll see. See the pop, the bend in the vein, and the giveaway, and then it's moving inside. And now that's how you slip in the cannula. Simple.
And one more technique which helps is as soon as you have a giveaway, as soon as you see, feel the giveaway, immediately parallel, stop your further progression, and instead of going further, just parallel straight, so that you don't miss that chance. Because number of time people, as soon as they feel the giveaway, still they continue to go, and then they're on the out of the lumen on the other side. So as soon as they feel the giveaway, stop, and then make it flat, progress further. It's very easy.
Once you've got a flashback of blood in the back of the cannula, you know you're in. Just stop. I always say, breathe. Just for 2 seconds. Don't get excited. And just as Ashfaq said, just make it parallel to the patient's body and just slip it in like this guy is doing. Okay? So he's now, see, look, he has changed the angle now. It's gone much flatter and then push the cannula in. Okay? Simple. So this is central venous axis, probe position. I will show you that as well. This is medial, this is lateral, this is, I think, 9 o'clock position. And what you're going to see, this is the probe position, this is the earlobe, this is distal, this is proximal. What you're going to do, once the probe is placed here, this is how it will look like. This is the sternocleidomastoid, this is the internal jugular, this is the carotid, and this is the thyroid gland. And see where the probe is? See? Remove the sternocleidomastoid, you see the vein, then you see the carotid and the thyroid further medially. Simple?
So can you see that this internal carotid, if you see this internal carotid, how close it is, isn't it? How many of you still do without ultrasound internal jugular? You guys do it, isn't it? But that's considered as a crime. It's a crime now, it's a negligence. The NICE guidelines suggest you should not do internal jugular access unless you have ultrasound, no matter how experienced you are, because there can be a variable internal carotid artery sitting there and you can actually hit it because you are going blind, isn't it? So take home message is, it has to be done under ultrasound control. If any one of your hospital is doing it, you need to raise a question and start raising the concern that you should not be doing it blindly. Or I imagine if it's your father, if it's your mother, and someone is coming as a confident chap and he's trying to do it, will you let them do it? No. So this is a big crime now, so don't do it, okay? Thank you.
Again, the distance is just like literally 1 centimeter, 2 centimeter at most. वो नीडल अंदर डालते जाते हैं जनाब जी वर्टिब्रे के अंदर ठोक रहे हैं. That's what I say. So be very careful. Next image will show this chap is doing out of plane. And if we can show you the needle tip. See, this is the needle tip. Okay? And that's out of plane. Okay? And it's going in. See the pop? And he's keeping the needle tip in position. It's not gone beyond. Once he has seen the live image of needle going into the jugular, you hold and you breathe. And then you angulate it and you slide it in. Okay? Simple? It is simple. It's the simplest things in life. But you have to be in control. Don't get excited about it. And take a breather. Do it. Any questions? No questions? Good. आप ये स्किल्स जो है ना अगले 1 से 2 साल में भी सीख सकते हैं और शायद 10 साल में भी ना सीखें. A jelly on a belly a day is what my supervisor told me. The first thing he taught me was switching on the ultrasound machine, and he said, "Go away, learn something new tomorrow." That's it. Small steps में सीखें. एकदम से नहीं सीख सकते. Okay? Ultrasound guided facial iliac block. Have you guys heard of facial iliac block? I'm sure you must have. अशफाक भाई ने पढ़ाया सबको.
No, they haven't because
They haven't?
we have done the 100 procedure workshop there.
Oh, okay. No problem. So ultrasound guided facial iliac block. Why do we use it? I'm a huge fan of nerve blocks and regional blocks. That's you can say my forte, my passion, because anything that takes the pain away of a patient instantly, it's like magic. वो तो हमको खुदा समझने लगते हैं. आउज़ुबिल्लाह. ठीक है ना? अल्लाह ने आपको ये पावर दी है. If you just take 10 minutes to do over. Fascia like a block, basically used for hip fractures and soft tissue injuries on the anterior, medial, and medial side of the leg. Okay, anything in this area has got pain, fascia like a block, basically of the femoral division and lateral cutaneous nerve of thigh, that can be covered in the fascia like a block. You block those nerves, you put some local anesthetic there, and the patient is pain free. Simple. Contraindications. Overlying infections, patient is allergic to local anesthetic, patient says, I don't give a dash, so I don't want to get it done, so please don't do it. So you can't do that. Previous surgery to the groin, you can't do it. Anticoagulation or bleeding disorders. Now this is a relative contraindication in somebody who has got in which you are doing it ultrasound guided, which should be the standard now by the Royal College. So this is not a contraindication anymore, but if you're doing it blindly, it is a relative contraindication. It is a contraindication. Why? Because if hit a femoral artery and the patient is on warfarin or anticoagulant or aspirin, it's going to keep on bleeding, which you don't want. So don't take any risk. Don't take any chances. Be sensible and make sure that you're looking after the patient rather than your numbers of doing blocks and scans. Side effects: bleeding, overlying infection, bleeding, hematoma, nerve vascular injury if you're doing it blindly. The chance of nerve and vascular injury is very little if you're doing it ultrasound guided, and I'll show you why. Local anesthetic toxicity, yes. Allergy and anaphylaxis, yes. Apnea and heart failure, apnea and failure of the procedure. Apnea, if the patient's got local anesthetic toxicity, you can lead to that. Failure of the procedure, you're not God. You can't be 100% sure that if somebody's saying कि मैंने 100 या 200 procedures किए हैं and everything is successful, you can bet on it he's lying. Okay? There's no question about it. अक्सर सर्जन्स बोलते हैं कि मैंने तो इतनी सर्जरी की और मैं कोई कॉम्प्लिकेशन नहीं की, हो ही नहीं सकता. It's not possible. मैंने अपने फर्स्ट 3 months ऑफ 4th ईयर में मैंने लास्ट 3 months ऑफ 4th ईयर में मैंने 50 ब्लॉक्स किए थे. ठीक है, और मेरे कोई 4 फेलियर थे इसके अंदर, जिसमें मैं 1 मिनट टीच कर रहा था. Due to various reasons, but you have to be honest with the patient. Okay? So this is fascia iliaca. As the name itself indicates, it's above the iliacus muscle. muscle. It is a fascia, as you can all see. There's no rocket science to it. What you need get below the fascia next slide. And once you can anesthetize these main nerves, you can get the patient free of pain. Obturator nerve, femoral nerve, lateral femoral cutaneous nerve. These are the three targets that you're trying to anesthetize. How you try to anesthetize? You go underneath the fascia where these three nerves are lying. You inject a local anesthetic. You literally flush it with local anesthetic, 30 to 40 mLs of 1% liver, 2.25% liver bupivacaine, long-acting local anesthetic. That's you're going to inject. Make sure you're not injecting the vessel, and bingo, the work is done. Okay? And this is how it's going to be done. I'll show you. डॉक्टर अली हम लोग कर रहे हैं यहाँ पे एवर केयर में फेशियल का अब करना शुरू कर दीजिएगा इंशाल्लाह. This is the inguinal ligament. This is the anterior superior iliac spine. This is the probe position. You slide it down just below the inguinal ligament. Okay. There are two approaches. One is a suprainguinal approach, and one is an infrainguinal approach. The reason why they call supra and infrainguinal approach, in suprainguinal approach, you still place the probe infrainguinally, but you deposit the local anesthetic above the inguinal crease. And infrainguinal approach, you still approach it infrainguinally, but you deposit the local anesthetic below the inguinal ligament. Why and what's the rationale behind it? I'll explain to you. We'll first learn the landmarks of suprainguinal approach. You put the probe anterior superior iliac spine, roughly around here, you slide it down, and you see these structures. I'll show you the zone anatomy. This is a very important structure, deep circumflex iliac artery. So once the probe is slide down, you inject you put the needle in inferiorly in plane, okay, and avoid this deep circumflex iliac artery. Okay, so needle is coming from here underneath the inguinal ligament all the way here. Understand so far? Okay, so inferior to superior. And this is what the anatomy will look like. It's going to come in a second. This is head end, this is foot end, this is sartorius, this is the internal oblique, this is the iliopsoas muscle, this is the fascia iliaca, this is the first bulb, second bulb. Underneath the second bulb is the deposition of local anesthetic on the iliopsoas muscle. And once this local anesthetic is spreading, that's the same facial plane in which the nerves are lying. Understand? Okay. How does it look like? Okay. Again, look at the suprainguinal approach. This is the pelvic brim. This is the iliacus muscle. This is the deep circumflex artery. Sorry, deep circumflex iliac artery. And if you see this is foot end, this is head end. You approach the needle from inferior and you go above. Okay? This is the needle coming in all the way down. I'll show you the next slide is very nice. We'll see what's called the unzipping of fascias, unzipping of the muscle. This is what you need to get to. This is again the suprainguinal approach. This is the foot end. This is the head end. You introduce the needle in between the fascia and inject the local anesthetic. It appears like a black. It's got a black appearance. This is the needle coming, approaching, hit the interfacial plane, inject the local anesthetic, and you see it unzipping the two fascias, the fascia separating from the muscle.
So both these fascias will open like that as soon as you put
unzip it. Okay.
It takes less than 10 seconds to do this block. It doesn't take long time.
So ये वीडियो बिल्कुल नहीं चल रही है तो मजा ही नहीं आ रहा
But I think you have explained it very nicely. Let's move forward and let's start hands-on because
yes.
we.
Okay, infrainguinal approach. Infrainguinal approach. Just start 5 minutes.
छोड़ दे infrainguinal.
छोड़ दे.
इनको वही वाली
तो बस anatomy दिखा देता हूँ infrainguinal की just one, and if we can show them over there, that would be great.
Because I practice suprainguinal. That is, sorry,
yes.
The one approach which will teach you in practical session, and so.
Just one image and it will be done. Again, it's stopped.
Is this your last session, isn't it?
Just last khatam, last slide.
चलें अब hands in practice करते हैं, ठीक है? Thank you very much.